we call the next speaker, and a rare case of bilateral disc drusen with peripapillary choroidal neovascular membrane in young Pradeep. Yeah, Pradeep. Yeah.
Good morning, all. Today I will be presenting a case of
Little louder.
Today I will be presenting a case of peripapillary CNVM in a young female patient. Coming to the case, patient was a 20-year-old female presented with decrease in vision in left eye since 5 days. There was an associated headache with the holocranial nature. There was no any medical history or any significant past history. On examination, right eye was within normal limit with normal intraocular pressure. Left eye was 6/12, not improving, and contrast sensitivity mild decrease was there in the left eye. On examination, right eye fundus, the media was clear. There was crowded disc with indistinct margins. Cup disc was obliterated with foveal reflex present, and macula appeared normal. Whereas left eye fundus showed us crowded disc associated with indistinct margin, and cup was obliterated with peripapillary yellow lesion temporarily with subretinal hemorrhage. Also, we noted that superiorly the localized small round elevations there were suggestive of superficial drusen were noted. On examination and evaluation on clinically, we decided it to be both eye optic nerve head drusen with left eye peripapillary CNVM. So further evaluated with B scan, wherein we noted that bilaterally there were hyperechogenicity with high reflective in nature noted. Also, fundus autofluorescence showed hyper autofluorescent round structures in disc with irregular edges in both eyes, which were more significant in the left eye. And right eye OCT of the disc showed us disc elevation with signal poor core surrounded by a hyper reflective margin, and backshadowing was noted. In left eye also, disc elevation was significantly noted with signal poor core surrounded by hyper reflective margin and backshadowing. Also, there was SHREM with subretinal fluid noted. And octa of left eye particularly showed us the vascular network in the deep retinal plexus in the slab, which was suggestive of type 2 CNVM. So treatment was decided to be left eye intravitreal anti-VEGF appropriately was decided, but what we noted was like patient didn't follow up with us. So I want to go through a few discussion on the optic disc drusen. Basically, they are the acellular deposits of calcium, amino and nucleic acids and mucopolysaccharides causing chronic optic neuropathy in a long duration. These are usually located in the lamina cribrosa in the optic nerve head, may be superficial or buried. So epidemiology incidence varies from 0.4 to 2.4%, can be unilateral or bilateral, mostly asymptomatic. Location wise, nasal to the disc are more common. So with age, we have noted that the visibility of the disc drusen increases. For example, in the 7th or 8th decade, it will almost be seen in most of the patient. So these are often buried in the young age, so visible at the disc surface in 2nd to 3rd decade normally. So precursors are small optic cup, small scleral canal and small disc area. Pathogens would be any genetic predisposition, and as I mentioned the previous chronic obstruction due to the small cup or scleral canal. So this in turn causes extrusion of the calcification material, then formation of the optic drusen, further damaging the exoplasmic flow. So clinical features of any such cases with only disc drusen would be asymptomatic and very rarely may have 24 to 85% of adult population with visual field defects. Associations would be any kind of glaucoma, papilledema, RP, angiostrix. Systemic, there are noted that rarely algilar syndrome, pseudoxanthoma elasticum and phacomatous. Even one of the cases had noted that disc drusen are associated with the idiocranic intracranial hypertension. So complications of disc drusen would include optic ischemic, non-arteritic ischemic optic neuropathy, vascular occlusions, peripapillary choroidal neovascular membranes, retinal hemorrhages. So underlying optic disc drusen, basically they cause the vascular compression, altered autoregulation, thus leading risk of vascular complications. So the pathogens would follow the similar type of CNVM, which direct mechanical compression, impaired peripapillary circulation, thus increasing the level of VEGFs and forming the type 2 CNVM. So most of the peripapillary CNVM were treated with anti-VEGFs and had a good result, which required 1 to 3 number of anti-VEGFs. Differential diagnosis would be congenital disc anomalies, infiltrative lesions, vitreopapillary tractions, LHON. Also, the recent entity PHOMS, that is peripapillary hyperrefractive ovoid mass-like structures, can also mimic like a optic disc drusen. Also tilted disc, MNF, crowded disc, and idiopathic intracranial hypertension. Just like differentiating features from PHOMS and the optic disc drusen include in PHOMS, which is a newer entity, OCT finding seen are there will be papilledema associated and tilted disc would be there, and maybe having the optic disc drusen and pseudopapilledema. These correspond to herniating nerve fiber actually, and lateral bulging into the peripapillary retina would be seen. Some hypothesize that these are the precursor lesion to the optic disc drusen.
Yeah, time is up. Yeah. Very nice, Pradeep. Just wanted to know, you have done all the TSR.
Is CNVM, how often is it associated with optic disc drusen? How often CNVM is associated with pseudo?
What is the incidence of CNVM?
It's quite rare, sir. So
With
that
a
we
very-
took it a very that to bilateral with optic disc drusen. Association in the young female was rare because
Yeah.
the optic disc drusen itself is a long duration process where it causes the ischemia by the axocosmic flow obstruction. So it was in a young female of 20 years. It was little rarer entity which we studied.
Yeah, because I haven't seen it.
Yes.
I have seen lots of drusens, but I haven't seen CNVM. And number two, was there a leakage on fluorescein angiography?
Yeah. Why you didn't do fluorescein and ICG?
Since we got it in the octa, and also patient was little apprehensive with the 20-year female, and she was somewhat apprehensive with the invasive procedure. So with octa, we just went ahead, sir.
You didn't show. Did you show the outcome?
Yes, doctor.
Yeah, I saw that photograph.
Okay.
But
Network
there
was there.
you see, there is no need of anti-VEGF if there is no leakage at all.
In octa, we had the active network, sir, with subretinal fluid.
No, that is shown in the OCT also. We
Yes.
saw that. Yeah. So anti-VEGF. What anti-VEGF you gave?
Ranibizumab.
Ranibizumab. Okay. I think Eylea is the better. Aflibercept is better for this long acting.
Only one dose?
Sir,
No.
actually, this patient we could not follow up because she lost a follow-up, sir. Only one single this was there. But when we just called by the telephone, they told that they got treatment somewhere else.
Somewhere else.
Yes. And the visual prognosis
vision-
was, she was stabilized.
What is the vision?
She didn't tell the particular. She told they have improved, sir.
Okay.
Thank you.
Any questions from the audience? As long as the OCT shows activity. My suggestion is aflibercept for these patients. The longer acting and rather than ranibizumab, it works very well for these patients. I'm not sure about Vabysmo now, but we don't have very good results with Vabysmo. But aflibercept Eylea is probably the best for this. But as long as we need to follow up on long term, because there's a possibility the same CNVM can occur in the fellow eye as well. So once you have optic nerve drusen in both eyes, and that's a big problem. And FFA ICG is a must. The reason why we need to do, because FFA ICG is we have to document the nature of the CNVM, number one, and it will be a baseline documentation for you to know in the future. Since the patient is quite young as well, you need to document, and probably subsequently you can do OCT, octa, whatever it is, but baseline angiogram is very, very important, right?
Yes.